Assalamu alaikum and welcome back. As we discussed a few videos from the series Let's Diagnose ECG. Now in this video we will discuss 10 ECG cases together. So note down all the important points that you will learn from this video, and if you have any confusion regarding any question or any ECG case, you can mention in the comment box below. So let's get started. पहले 3 केसेस हम ऑलरेडी डिस्कस कर चुके हैं इन आवर प्रीवियस वीडियोस, जिनकी लिंक मैंने डिस्क्रिप्शन में दे रखी है, आप उन्हें जाके ज़रूर देखना. नाउ हियर इज़ आवर फोर्थ केस. A 35 years old football player developed this rhythm during exercise on ergometry. We have given 4 options here. First is normal sinus rhythm, second is junctional rhythm, third is Brugada syndrome, and the last is coronary sinus rhythm. Let's analyze this ECG first. The heart rate is 68 beats per minute. Rhythm is regular. In this ECG, no P waves can be seen. QRS complex is positive in lead 1 and lead 3, which shows normal axis. Also, QRS complexes are relatively narrow. Thus, in summary, this ECG suggests junctional rhythm, that is given here as the second option. Let's check our answer. It's correct. Now we have the 5th case here. A 65 years old female comes for a consultation and complaining about vertigo and tiredness. We have given 4 options here. First option is second degree AV block Mobitz type second. Second option is second degree AV block Mobitz type first. Third option is third degree AV block, and the last option is right bundle branch block. Let us see this ECG. The heart rate is 60 beats per minute. Rhythm is regularly irregular. The QRS complex is upright in lead 1 and downwards in lead 3, which shows the left axis deviation. The PR interval in conducted beats is constant. Each P wave is associated with a QRS complex until there is no P wave that is not followed by a QRS complex. Also, the P waves march through at a constant rate. Here I would like to mention an important point that Mobitz type first and type second degree AV block cannot be differentiated from each other when a 2:1 AV block is present. In this situation, every other P wave is non-conducted and there is no opportunity to observe for the constant PR interval that is characteristic of Mobitz type second degree AV block. In summary, this ECG shows second degree AV block Mobitz type second, that is here as a first option. Let's check our answer. It's correct. Now here is our 6th case. A 58 years old male with a history of hypertension, dyslipidemia, diabetes mellitus presents with 45 minutes of severe chest pain. We have given 4 options. The first option is anterior STEMI, second option is left ventricular aneurysm, and the third option is atypical atrial flutter. The last option is pericarditis. As we can see in this ECG, ST elevations in V1 to V4 and also reciprocal ST depressions in inferior leaders. Thus, this ECG suggests anterior STEMI, that is given here the first option. So let's check our answer. It is correct. Here is a 7th case. A 57 years old male brought to the hospital for acute chest pain. We have given 4 options. First is hyperkalemia, second is de Winter's pattern, third is non-ST elevated myocardial infarction, and the last is right bundle branch block. As we can see here in this ECG, upsloping ST depression at J point with more than 1 mm in precordial leads. Also, tall prominent symmetrical T waves can be seen in precordial leads. Slight ST elevation in augmented vector right lead can be seen. Thus, this ECG suggests de Winter pattern. The de Winter pattern is an atypical presentation of acute myocardial infarction due to left anterior descending artery occlusion. It is considered an STEMI equivalent and implies the need of urgent coronary angiography with the possible of intervention. De Winter pattern is given here as the second option. So let's check our answer. It's correct. Now we have the 8th case here. A 43 years old female with a history of migraine and was recently diagnosed with hypertension came to the doctor complaining about severe headache. We have given 4 options: STEMI, pericarditis, short QT syndrome and subarachnoid haemorrhage. As we can see in this ECG, the heart rate is 58 beats per minute. That is the signs bradycardia. Rhythm is normal. QRS complex is upright in lead 1 and lead 3, suggesting normal cardiac axis. QRS complexes are narrow. QT interval is slightly prolonged. The TV abnormalities can be seen in precordial leads. In summary, this ECG suggests subarachnoid haemorrhage as given here as the last option. Let's check our answer. It is correct. Now we have the 9th case here. A 58 years old male with known medical history of hypertension and asthma comes to his doctor with complaints of cough, bilateral leg swelling and difficulty in breathing for 2 weeks. We have given 4 options: left anterior fascicular block, anterior STEMI, right bundle branch block, and the last option normal sinus rhythm. As we can see in this ECG, the M pattern in lead 1 and W pattern in lead V6 and wide slurred S waves in lateral leads, that is lead 1, AVL, V5, V6. Also the broad QRS complexes can be seen. Thus this ECG suggests right bundle branch block, that is given here as the 3rd option. So let's check our answer. It is correct. Now we have the 10th case here. A 47 years old female with a medical history of hypertension and COPD was recommended for a cardiology examination for the pathologic ECG findings and recent peripheral edema. We have given 4 options here: atrial fibrillation, right bundle branch block, long QT syndrome, and the last option right ventricular hypertrophy. As we can see here in this ECG, QRS complex is downwards in lead 1 and upright in lead 3, which is a right axis deviation. Also we can see the dominant R waves in V1 and deep S waves in lateral leads. These ECG features suggest right ventricular hypertrophy, which is given here as the last option. So let's check our answer. It's correct. Now we have the 11th case here. A 60 years old male brought to the emergency department for the loss of consciousness. We have given the 4 options. As we can see in this ECG, the widespread horizontal ST depression most prominent in leads 1, 3rd and V4, V5 and in V6. ST elevation in AVR and V1, suggesting left main coronary artery occlusion, which is given here as the 3rd option. So let's check our answer. It's correct. Now here we have the 12th case. A 35 years old male without a structural heart disease examined for palpitations. We have given here the 4 options: typical atrial flutter, atrial fibrillation, atrial tachycardia, and the last fascicular ventricular tachycardia. As we can see here in this ECG, the left axis deviation is present with right bundle branch block morphology. Also ventricular tachycardia with relatively narrow QRS complexes can be seen. This ECG suggests fascicular ventricular tachycardia, that is given here the last option. So let's check our answer. It is correct. Thank you for watching this video. Please share and subscribe this channel.